Let's take a look at this case now. We have a 19-year-old woman, and we are given a lateral x-ray and a cone down view of that lateral x-ray. What do you see? You got it. If you see this area of sclerosis that's thickened on the dorsal aspect of the proximal tibia, you've got sharp eyes. And we don't expect the cortex to be thickened in that particular region. That's not the weight-bearing portion of the bone, generally speaking, along the anterior cortex that occurs. So we'll investigate this further as a long area of apparent sclerosis and cortical thickening in the proximal tibia. And you named it. We did our axial CAT scan, and what do we see? Cortical thickening, and within the cortical thickening, a lucent lesion. Best diagnosis? Osteoid osteoma. This is a lesion, 10% of all benign bone lesions. It occurs that it happens with pain at night, relieved with rest. It's composed of a nidus, a central vascular tangle, seen here in this talar neck. There is a fibrovascular rim, and then it induces a inciting reactive surrounding sclerosis. The distribution is usually cortical. When it's in the talus, it can also be subperiosteal. And 60 to 80% of the long bones, most commonly in femur and the mid-tibial diaphysis, 20% occur in the phalanges, and 10% in the posterior elements. So it's a good one to remember for that. Osteoid osteomas, we're going to use CT as the modality of choice. We can see it in nuclear medicine as a double density sign, paralleling that vascular nidus and that fibrovascular rim. MRI, we can see lesions and we can pick them up, which means they're sensitive. We can see it, but we don't know exactly what it is. It's not specific. Treatments of these lesions include radiofrequency ablation. And there's a differential diagnosis. Not every one of them looks perfectly like a little nidus and surrounding sclerosis. So the differential, like for instance, in this distal fibula where we see that there is some vague area of increased sclerosis, that the cortical bone is as high as the medullary bone, may be seen in entities such as Brody's, where we have patchy sclerosis surrounding an area of metaphyseal infection. Or an osteoblastoma can appear greater than 2 centimeters in size. There's a differential in the size for osteoid osteoma versus osteoblastoma. So the larger it is, more likely it is an osteoblastoma. Sclerosis and irregularity can present as a stress fracture. And of course, we can have cortical desmoids. Regarding osteoid osteomas, all of the following are true except, get back to our osteoid osteoma example where we're seeing this region of thickened sclerosis along the dorsal aspect of the proximal tibia. Is it A, the most common location is the femur followed by the tibia, or B, for intracapsular lesions, the most common location is the femoral neck, or C, osteoid osteomas are more frequent in the sacral spine, or D, surgical resection requires removal of nidus and surrounding periosteal reactions? What do you think? And if you pick C, osteoid osteomas, they're not more frequent in the sacral spine. They're more frequent in the lumbar spine. And of course, the other features are true. Regarding osteoid osteomas, most common location femur. For intracapsular lesion, most common location is the femoral neck. And surgical resection requires removal of nidus. The radiofrequency ablation method is actually preferred following failures of conservative therapy.